Have you ever felt like you're just, you know, drowning in information? Stacks of articles, notes everywhere, and you just wish someone could pull out the key stuff.
Absolutely. Like you
Yeah.
need a shortcut, right? Just the vital insights, clear and ready.
Exactly. Without that information overload feeling. Well, if that sounds familiar, you are definitely in the right place today.
Uh-huh.
Today we're doing a deep dive into a topic, enteral nutrition in hospitalized adults. Now that might sound a bit technical.
It does, maybe a little dry.
Yeah, but trust us, this isn't just about like hospital food trays. It's way more fundamental. It's about a critical, often life-saving intervention.
That's a great way to put it. And our mission for you today really is to cut through something like 15 years of pretty intense research in this field.
15 years, that's a lot of ground to cover.
It is. Practices have evolved. There have been some truly groundbreaking trials, so we're going to unpack it all.
Highlight those aha moments, maybe.
Exactly. Show you why this matters so much for patient outcomes.
And we've got some solid sources for this. Tell us about those.
Yeah, they're really good. We're leaning heavily on a comprehensive review article, brand new, actually, from April 2025
Okay.
by Dr. Leah Gramlich and Dr. Peggi Guenter. And we're pairing that with a detailed timeline that maps out key research and guidelines over the last 15 years.
So those sources really pull together decades of learning, don't they?
They really do. It's a consolidation of so much work. So whether you're, prepping for a meeting or just trying to catch up on medical advances.
Or maybe you're just curious.
Or just curious, yeah. By the end of this, you'll feel remarkably well informed on this.
All right, let's get into it then. Enteral nutrition, or EN. What, at its core, are we actually talking about?
Okay, so the precise definition is the provision of essential nutrients through an enteral tube.
An enteral tube, right, like a feeding tube.
Exactly. And the goal is to prevent or treat disease-related malnutrition in patients who are unable to consume adequate nutrients by mouth.
So it's for when people just can't eat enough on their own.
That's the essence of it, getting those vital nutrients directly into the gut.
And you mentioned it's often underutilized. That seems surprising for something so fundamental.
It really is quite striking. You think, okay, someone's in the hospital, they must be getting fed properly. But the numbers paint a different picture.
What do they show?
Well, first, the scale of the problem. Get this. 30 to 45% of hospitalized adults are malnourished when they're admitted.
Wow, almost half in some cases. That's huge.
It's huge. And then here's the kicker. EN, the specific intervention, was only used in about 5.2% and 4.9% of malnourished hospitalized patients in the United States and Europe, respectively, in recent studies.
That low. So we know malnutrition is rampant, but the specific tool to address it isn't used nearly enough.
Precisely. It screams, that there's a critical need to identify patients with disease-related malnutrition much, much better.
Okay, so let's unpack that term. Disease-related malnutrition. You said it's more complex than just not eating enough.
Much more complex. DRM, as it's called, is really a syndrome. It involves inadequate nutrient intake, sure, but also insufficient nutrient utilization.
Meaning the body can't use the nutrients properly?
Exactly. And crucially, there's often disease-related systemic inflammation playing a big role.
Inflammation again.
Right. And this whole mix leads to altered body composition and diminished bodily function. The body starts breaking down muscle, function declines.
And the consequences sound pretty severe.
They are. We're talking a higher risk of death, prolonged hospitalization, hospital readmission, and, of course, high healthcare costs. It's a major issue.
Okay, that makes sense. Now, just quickly, terminology. We hear medical nutrition therapy, MNT, and nutrition support. Are they the same thing?
Good question. Not exactly. MNT is the bigger umbrella term.
Yeah.
It covers a whole range, including patient counseling, things like oral nutritional supplements, and EN, and parenteral nutrition.
Parenteral meaning IV feeding.
Right, 5E feeding. So MNT is broad. Nutrition support is more specific.
Right.
It usually refers just to the EN and PN, the tube feeding and IV feeding.
Got it. MNT is the whole strategy. Nutrition support is the feeding part.
You got it.
And speaking of MNT, you mentioned a game-changing trial earlier that really highlighted its importance.
Ah, yes, the EFFORT trial. That was truly a landmark study published in 2019.
What did EFFORT show?
It showed that when you provide individualized MNT, compared to just standard hospital care, patients actually got higher mean daily caloric and protein intake. That might sound obvious, but
But did it make a difference in outcomes?
that's the key, yes. It led to lower odds of an adverse outcome overall and significantly lower mortality.
Lower mortality. That's powerful evidence. Was this finding backed up elsewhere?
It was. Around the same time, in 2019, a big meta-analysis came out.
Right.
And it confirmed the effort findings, really. It showed MNT significantly reduced the risk of death, actually by 27%, even up to 6 months after discharge.
Wow, that's a lasting effect.
Huge. And it also decreased non-elective hospital readmissions, improved intake, helped with weight. It really solidified the case for taking nutrition seriously, individually.
Okay, that really sets the stage for why this matters. So, how did we get to this understanding? It wasn't always this clear, was it? What do things look like, say, before 2010?
No, definitely not always this clear. You're right, before 2010, the field was, well, still maturing. MNT and nutrition support were often used, interchangeably.
It's fuzzy.
A bit fuzzy, yeah. And the guidelines that existed, especially outside the ICU, often lacked support from good quality clinical evidence. There was potential for bias. It was really time for more rigorous research.
And it sounds like some early studies started to push back against older ideas, maybe hinting that not feeding enough was actually harmful.
Exactly. There was a study back in 2005 by Leah and colleagues that first suggested this negative impact of hypocaloric feeding, that not giving enough calories could be bad.
That seems basic now, but maybe wasn't then.
It was a key shift. Then you had observational studies, like one in 2009 by Alberta and Gramlich, and a multi-center study in 2010 by Ji and Jiang.
What did they add?
They started showing a more direct impact of nutritional support on clinical outcomes for patients who were at nutritional risk, building the evidence brick by brick.
Okay, so the evidence for doing nutritional support was growing, but how do we get better at actually identifying who needed it? You can't treat malnutrition if you don't diagnose it properly.
Absolutely critical point. A major step forward was a 2012 consensus statement.
Consensus, getting experts on the same page.
Right. Led by White, Guenter, Jensen, and others, it laid out specific characteristics for malnutrition identification. This wasn't just subjective anymore.
And that led to standardized criteria.
Precisely. It paved the way for adopting tools like the GLIM criteria and AM criteria. These give clinicians clear, objective frameworks to diagnose malnutrition consistently.
Makes sense. Standardize the diagnosis. Now, you mentioned inflammation earlier as part of disease-related malnutrition. How does that inflammation actually mess with the body's ability to use nutrients?
It's a huge factor, and it makes things really complex. DRM isn't just about lack of intake, it's this multifactorial thing involving poor appetite, muscle wasting, and yes, that disease-related inflammation.
We can measure this inflammation.
Often, yes, using markers like CRP, C-reactive protein. If CRP is really high, say over 100 milligrams per liter, it can actually reduce how effective MNT is.
Really? So the inflammation itself fights the therapy?
In a way, yes. The effort trial actually found in a subgroup analysis that MNT didn't show a benefit in patients with those really high CRP levels. The body's just in such a different state.
What kind of state is that, metabolically speaking?
Well, during critical illness, metabolism goes haywire. Energy use might actually decrease initially. Macronutrient use changes the body prioritizes glucose. And there's often excessive protein breakdown. The body starts eating its own muscle, leading to that rapid skeletal muscle wasting, especially in the first week.
Scary stuff.
It is. Plus, you get anabolic resistance, meaning the body resists building tissue, and insulin resistance, making it hard to manage blood sugar even when you're giving nutrients.
Like pouring water into a leaky bucket, you said.
Exactly. The body just isn't receptive in the same way.
So all this complexity, especially in critical illness, leads us to this really interesting, maybe counterintuitive debate. Underfeeding versus full feeding in the ICU.
Yes. This has been a major area of research and, frankly, changing perspectives.
Because you'd normally think more calories must be better, right? Especially for someone who's sick.
That was the traditional thinking, but some key trials started challenging that. Eden, back in 2012, compared minimal or trophic feeding versus full feeding. And the Calories trial in 2014 looked at similar calorie amounts given either enterally or parenterally. Neither found big differences in mortality, which was surprising.
So maybe more wasn't always better.
Exactly. And then came Nutri-Year 2 in 2018. It found that pushing high-dose EN early on was actually linked to more digestive problems.
More complications, not fewer.
Okay. And then the real bombshell, maybe, was Nutri-Year 3 in 2023.
What happened there?
This trial looked at ventilated adults with shock, so very sick patients. And it actually found harm in the high-dose nutrition group. How so? They had a longer stay in the ICU and more complications. This really solidified a shift in thinking.
So what's the current thinking then? Why would less food be better initially?
The hypothesis now is that underfeeding, maybe giving less than 70% of the calculated energy needs in that very acute phase, might actually support an adaptive metabolic response.
Adaptive, meaning it lets the body focus on fighting the immediate crisis.
Something like that. It's about maybe not overwhelming a system that's already under immense stress, respecting that acute inflammatory state.
Fascinating. So if less is sometimes more for calories in the acute phase, what about protein? That's always talked about as crucial for healing.
Ah, the protein puzzle, yes. Another huge area of debate and ongoing research.
There was a big trial on this recently too, right? The effort protein trial.
Yes, 2023, highly anticipated. And its findings were, well, quite striking.
What did it find?
It found that giving higher protein dosing did not shorten the time to discharge from the hospital or reduce mortality.
Okay, so no benefit on those key outcomes.
Right. And importantly, it suggested potential harm in patients with acute kidney injury and high organ failure scores.
Harm again. So more protein could actually be bad for the sickest patients.
In certain situations, like acute kidney injury, the trial suggested yes. However,
There's always a however in science, isn't there?
hey, usually, you're right to ask because it's not quite that simple. While effort protein raised concerns, another big recent meta-analysis, also from 2023,
Okay.
by Van Ryven and colleagues, looked across many studies. It found little reduction in mortality and no harm associated with the provision of more than 1.2 grams of protein per kilogram per day in a broader group of critically ill patients.
So, conflicting signals. One trial suggests harm in specific groups. A meta-analysis suggests no harm overall. How do clinicians make sense of that?
It highlights the nuance, doesn't it? It means more protein is better isn't a universal rule. It likely depends heavily on the patient's specific condition, kidney function, severity of illness.
So it's about the right amount for that patient, not just jamming in more.
Exactly. It's about tailoring. As Leah, Stopp, and others discussed in 2024, two half-truths don't make one truth. We're still refining how to optimize protein for different critical illness scenarios.
Right. Very context dependent. Now, most of this discussion, underfeeding protein debate, seems focused on the ICU. What about patients on regular hospital wards? Do these same ideas apply?
That's a crucial distinction. No, they don't apply in the same way at all. Outside the ICU and non-critically ill patients, underfeeding can actually be harmful.
Harmful. How so?
Well, studies have linked low food intake in these patients to an increased risk of infection. There was a study in 2015 showing this.
Okay, so the risk flicks outside the ICU.
It seems so. And a really dramatic example was the OPENS trial in 2022. It involved patients with severe stroke.
What happened?
They had to stop the trial early. The group getting lower calorie, hypocaloric, enteral nutrition had significantly higher 90-day mortality.
Wow. Stopped early due to higher deaths in the underfed group. That's a very clear signal.
A very stark difference from the ICU findings, yes. It underscores that the context, critical versus non-critical illness, is paramount.
So not a one-size-fits-all approach by any means.
Definitely not. And in other contexts, like surgery, the benefits of early and adequate EN are much clearer.
Like for post-op recovery.
Exactly. Multiple studies, including a big Cochrane meta-analysis in 2019, show that early EN, especially after major surgeries like esophageal cancer surgery, leads to greater energy delivery and significantly fewer pulmonary infections.
Fewer lung infections. That's a major benefit.
Absolutely. So the strategy really needs to match the patient's phase of illness and recovery.
Which brings us nicely to the practical side. How do we actually do this effectively? It's not just about the science, it's about applying it at the bedside. And maybe the first step is the patient themselves.
Oh, absolutely. The patient-centered approach is fundamental. You have to incorporate a patient's values, beliefs, and goals in shared decision-making.
Why is that so key for EN acceptance?
Because if the patient doesn't understand why they need a feeding tube, or if it clashes with their beliefs or fears, they might refuse it or not adhere to the plan. Getting buy-in is crucial.
Makes sense. Then there's the hardware, getting the tube in the right place. What's the thinking on enteral access?
Right, getting the tube in safely and effectively. For short-term use, say less than 6 weeks, we usually use nasoenteric tubes through the nose.
Yeah.
For longer needs, more than 4 or 6 weeks, it's usually percutaneous tubes placed directly through the skin into the stomach or intestine.
And where the tube ends matters too, right? Stomach versus intestine.
Yes, there's evidence suggesting that post-pyloric feeding, placing the tube tip beyond the stomach, into the small intestine might be safer for some patients.
Safer how?
A 2021 meta-analysis found it was linked to a lower incidence of pulmonary aspiration, gastric reflux, and pneumonia compared to feeding directly into the stomach.
Lower risk of stuff going down the wrong pipe, basically.
Essentially, yes.
Yeah.
Especially important for patients at high risk of aspiration.
And for those longer-term tubes, are there better ways to place them? Surgically? Endoscopically?
Good question. A 2021 study actually showed a clear safety advantage for tubes placed endoscopically using a scope.
Compared to other methods?
Yes, compared to tubes placed using fluoroscopy, X-ray guidance, or surgery. Endoscopic placement had a significantly lower risk of inpatient adverse events, death, and readmission.
Interesting. So less invasive seems safer there. What about the actual liquid food, the formulas? Do they cover everything a patient needs?
Generally, yes. Standard formulas are designed pretty well. If a patient is getting a decent volume, say at least 1,500 kcals per day, they usually meet most micronutrient and protein needs.
But what if they're getting less than that? Maybe due to underfeeding protocols or interruptions?
Right. If the volume is lower, then supplemental protein and micronutrients may very well be required to make sure there are no deficiencies. You have to watch that closely.
Okay. Now, you touched on safety improvements, connectors you mentioned. Tell me more about that ENFit.
Ah, yes, ENFit. This is actually a really big deal for safety. It's about designing enteral-specific connectors.
Meaning connectors that only fit other enteral devices.
Exactly, to prevent enteral misconnections. Historically, it was tragically possible to accidentally connect an enteral feeding tube to an IV line or a respiratory device.
Oh, wow. That sounds incredibly dangerous.
Potentially fatal. ENFit connectors have a unique design that physically prevents them from connecting to non-enteral lines. It's a massive safety step forward, rolled out fairly recently.
That makes so much sense. What other practical changes have improved things? You mentioned something about gastric residual volumes.
Yes, this was another huge practice shift. For years, standard practice was to routinely check gastric residual volumes, or GRVs basically, sucking back stomach contents to see how much feeding was left.
Right. To check if the patient was tolerating the feeding.
That was the idea. But a key trial in 2013 found that eliminating the routine measurement of gastric residual volumes didn't actually increase the risk of ventilator-associated pneumonia.
Really? No increase in pneumonia?
Nope. And what it did do was significantly improve the amount of enteral nutrition delivered, because nurses weren't stopping feeds as often based on arbitrary GRV numbers.
These patients actually got more nutrition without added risk.
Exactly. Now, guidelines suggest only holding feeds for very large volumes, like over 500 milliliters, if GRVs are checked at all. It was a major de-implementation of an old practice.
That's a fantastic example of practice changing based on evidence. Anything else on optimizing delivery?
Yes, the shift towards volume-based feeding.
Instead of rate-based feeding, what's the difference?
So rate-based is just setting a constant hourly rate, like 60 milliliters per hour. But feeds get interrupted all the time, right? For meds, procedures, patient intolerance.
Sure, happens constantly.
So with rate-based, you often end up delivering much less than the 24-hour goal. Volume-based feeding says, okay, the goal is 1,440 milliliters in 24 hours.
Right.
If the feed gets stopped for 2 hours, we'll increase the rate for the remaining hours to make up that deficit and still deliver the full 1,440 milliliters.
Ah, so it adjusts automatically to meet the total daily volume goal.
Exactly. And studies show it's superior to weight-based feeding for meeting caloric goals. It helps ensure patients actually get what's prescribed, despite interruptions.
Smart. Okay, lastly, on the practical side, metabolic management. What do clinicians need to watch out for when starting EN?
Two big things, mainly refeeding syndrome and glycemic control.
Refeeding, that sounds serious.
It can be. It happens when severely malnourished patients are refed too quickly. It causes dangerous shifts in electrolytes like phosphate, potassium, magnesium.
So you have to start slow.
Very carefully. Start low, go slow, and monitor electrolytes very closely, supplementing as needed. And the other is glycemic control blood sugar.
Especially in diabetics.
Yes, but even non-diabetics can get high blood sugar during illness and EN, so close monitoring and potentially adjusting insulin protocols are often needed, especially when starting or increasing feeds.
Got it. Okay, wow. We've covered a ton of ground here.
We really have.
This deep dive, it really shows how critical enteral nutrition is, doesn't it? And how it's often, surprisingly, underappreciated or underutilized.
Definitely.
We've seen the science evolve, moving from just feed people to this really nuanced understanding of dosing, especially in the ICU. That whole Less is sometimes more idea. It's fascinating.
It is, and the shift away from a one-size-fits-all approach towards really individualizing therapy based on the patient's condition and phase of illness.
And then all those practical innovations, the safer connectors, getting rid of routine GRV checks, volume-based feeding, making it safer and more effective at the bedside.
Right. All drawn from this amazing body of research and the kind of comprehensive reviews we base this discussion on.
But it's not like we have all the answers now, right? The field is still evolving.
Oh, absolutely. As the review article states, our understanding continues to evolve. There are still gaps.
Like what?
A big one is nutrition during recovery from critical illness. We're getting better at the acute phase, but there are no guidelines to guide nutrition care as patients transition out of the ICU and towards rehabilitation. That's a crucial next frontier.
That makes sense. The recovery phase is so important. Which kind of leads us to a final thought, a question for you, our listener, to maybe mull over.
Okay.
Given everything we've discussed, how vital EN is, how complex the science can be, and yet how it's still often underused, what role do you think things like technology, maybe AI, and definitely better interdisciplinary teamwork could play?
Yeah, how can we use those tools?
Right. How can we use them to make sure every patient who needs this kind of support actually gets it and gets truly individualized evidence-based care?
Not just in the ICU, but throughout their whole hospital stay.
Exactly. And maybe even continuing seamlessly into the recovery after discharge. It feels like there's still so much potential to improve outcomes by getting nutrition right consistently for everyone.
A really important question to consider as healthcare continues to evolve.